Heather? Kelly? Okay. All right. Determine and list the compensatory mechanism. And so for respiratory acidosis, in order for compensation to occur, we must see metabolic alkalosis, right?
Correct.
The opposite of respiratory is metabolic, and the opposite of acid is base. So for respiratory acidosis, the compensatory mechanism is metabolic alkalosis. Any questions with that? No? Okay. I'll wait till you all finish writing. Or I could drift off and stay right there. Come back, Kathy. Come back.
Be one of those days.
My mind is just... Okay. All right. All these blood gases up here are partially compensated. Because some of you struggled with this. Okay, that's going to be there. I'm not going to erase it, so let's focus on the quiz, and then I'll go over this. That'll be there, so let's look at the quiz. Okay, number 2 is respiratory alkalosis. So the compensatory mechanism, what's opposite of respiratory? Metabolic.
Metabolic.
And if the primary problem is alkalosis, then what has to compensate? Acidosis.
Acidosis.
Okay. Most of you did good on this part. Some of you still didn't get it. And you've got to know this. I mean, everything, of course, you're learning, you've got to know. But you won't be able to go on. And I've never said this, but everybody knows you got to get 84% or higher to pass each class. And you must know blood gases. Okay? And so I'm saying this to encourage you. This is the 6th week of school. You've kind of figured out the pace that you need to be at. And if what you're doing is not working, you've got to change strategies. I can't tell you how, what, but you've got to do something if you plan to continue on in this program, okay? You can't just be idle and occupy space. You got to get this. And for some of you, you've been right on from day one, but for some of you, you're struggling with blood gases. If you need help, come see me. I'm not going to keep telling you to come see me. I'm not going to beg you to see me because I know what you look like. But if you don't want to see me, you need to see somebody. And you need to do it right away. Okay? I'm not going to keep emphasizing. I'm not going to harp. I'm not going to preach. You know what you need to do. Right?
Yes.
Do it if you plan to be a therapist. I understand. I know. I'm the program director. I know what you're going through. I may not know what you're going through personally at home. You all are smart. You worked hard to get here. You're going to have to work harder to stay here. Okay? I'm not trying to make this difficult, but this is what's expected of you. If what I have on the board doesn't work, you got to find what works for you. This is how I understand it, but this may not be exactly what you need. Figure it out. I use the word, and when I use the word, I say cheat sheet. That doesn't imply your integrity. But as soon as you get a quiz, as soon as you get something with blood gases, you need to be putting something on that paper as a guide. Because you're not ready. Some of you aren't. Some of you are okay. You're not ready to put all this stuff together without this. Do something. I don't care if it's stars, daisies, whatever. you need to do something. Because the scores that I saw on these quizzes, I am not happy with for some of you, and you shouldn't be happy. And I can't go back. We've got to move forward. I haven't even gotten to the causes of metabolic, and this is the 6th week. I've got to move on, okay? If you need help, get help. So what I decided to do, also based on what I asked you all to do yesterday, the number one consensus, not everybody, but overall, everybody wanted help with the math for this class as well as cardiopulmonary A and P. And then the next thing was my 50-50 rule, respiratory failure and respiratory insufficiency. And the third thing was shunts. And that was consistent. Okay, some of the things that I saw, like the classifications of drugs, we haven't gone through all the classifications of drugs, so I'm not holding you to that. But what I'm going to do is tomorrow and next Thursday, and if I have to do it the following week, I am willing to stay after class up until 2 or 3 o'clock, and anything as far as math or whatever you want to go over. But when you come, you have to have specific questions, because I'm not going to sit and lecture again. You have to ask me specific questions, and I can provide specific answers and give you an examples. So those that are available tomorrow, if you choose to, it's not mandatory, because I got plenty of work to do in my office, believe me, I will make myself available right here in class after, 12:45. I will stay here till 2 or 3, however long it takes. That's all I can do for you, unless you come see me on an individual basis. Again, you don't have to see me. And I don't like to emphasize it, but it's in the syllabus. You got to have 84%. And so I am a woman of integrity, and I know I may come across harsh. That's only because I want the best for you. But I am a no-nonsense person. I am not. I like to laugh, have fun, but I am no nonsense. So you coming to crying to me at the end of 10 weeks, you really tried, and you don't have 84%, you cannot progress in the program. Do what you need to do. Understand? And I'm not saying any more because you all are adults. Okay, so let's move on. Metabolic acidosis, the compensatory mechanism has to be opposite, so it's respiratory, right? Mm-hmm. And the primary problem is acidosis, so then it has to be alkalosis. So the answer to number 3 is respiratory alkalosis. Yes?
Yes.
Yes.
All right. Number 4, metabolic alkalosis. The primary problem is metabolic, so what has to compensate is respiratory. And the primary problem is alkalosis, so what compensates is acidosis. Right?
Yes.
Any questions for 1 through 4?
Nope.
Number 5, some of you, I don't know if you didn't see it. Some of you didn't even answer it. Some of you gave me la, 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 la. Compensation means the pH is within normal range. That's all you need to know. That's all I was looking for. pH within normal range. That is compensation. And what compensates 1 through 4 are the compensatory factors that will help correct the blood gas. Okay? Any questions with number 5? All right. Number 6. When the pH is acid, what happens to the hydrogen ion? It increases. They're inversely proportional. When the pH is alkaline, what happens to the hydrogen ion? What happens? It decreases. Okay? All right. Now, number 8. Some of you all got this backwards. When the bicarb is acid. When the bicarb is acid, what is the pH? It's acid. So the hydrogen ion is elevated. It's an acid. See here? This is acid, right? What's the bicarb?
Increased.
Right. And when the bicarb is alkaline, what happens to the hydrogen ion?
Decreases.
All right, so this is what we have here. Let's take a bicarbonate acid. Let's start with metabolic acidosis. If you have a decreased bicarb, that means the pH is decreased, right? Because it's metabolic acidosis. Concur?
Yes.
All right. Then what happens to the hydrogen ion? It increases. Because these are inversely proportional. Make sense? Okay. And then the same here. If you have metabolic alkalosis, you have an increase in the bicarb, right? And if it's alkalosis, what's the pH? Up. And therefore, hydrogen ion is decreased. Does that make sense?
Yes.
Any questions? Okay. Number 10. Some of you struggle with this. Number 1, I want to tell you, go back to number 5. If a blood gas is compensated, the pH is what? Normal. So in these arrows and in number 10 and 11, if you told me the pH is normal, it's wrong. Because I asked for partially compensated. In a partially compensated blood gas, the pH is not normal.
Right, increase.
Any questions? Go back and look at number 5. What is the purpose of compensation? For pH to be between 7.35 and 7.45. Got that? Any questions? And don't be ashamed to ask a question, because if you don't know, somebody else in the class probably doesn't know either. That's good. As long as you see what you did wrong, you're right on. You'll never do it again. That's what I say. That's why we have erasers on pencils. Okay? All right. So number 10, it says in partially compensated metabolic alkalosis. Metabolic alkalosis. The bicarb is increased. Yes?
Yes.
Okay. Now, what compensates? Go back to number 1 or go back to number 4. The answers are here. If you go back to number 4, what compensates for metabolic alkalosis?
Respiratory acidosis.
So the PCO2 is increased. Yes?
Yes.
All right. And the pH, what's the primary problem? Alkalosis?
Yes.
So the pH has to be increased.
Increase.
Everybody see that? And some of you put the pH was normal, and I marked it wrong because it's not correct. Any questions? All right.
Ms. Miller,
Yes, sir.
I've got, I put the HCO3 is up and the PaCO2 is down, but I put the pH is down.
The pH is not down. A down pH, or down like that, decreased pH is acid. Look here, that's acid. A base pH is increased. And this one here, I believe, is what we're looking at. Is it the second one? Yeah, here it is. This is it. Okay, this is base. Maybe I need to use another color. I'll use green. This is base, yes?
Yes.
Yes.
And this is base.
Yes.
Yeah.
So that's the primary problem, metabolic alkalosis. But it's partially compensated, so we're going to see the opposite. What's the opposite of metabolic alkalosis? Respiratory acidosis.
Acidosis.
And there you go. Is that pH within normal range? No. So this is partially compensated metabolic alkalosis. See it?
Yeah.
Yes.
And we're not using numbers, we're just using arrows. Of course, you can write this down, and then an exercise for you is to put numbers with it. See, Kyle? You got to come up with something to put on your quiz or an exam for you to know this. If you put this, and it doesn't have to be what I have on the board, you figure out what's best for you. You figure out what's best for you. I'm just trying to show you something. Put this on your exam.
That works for me. It's something about not seeing the numbers, just.
Something about it doesn't care. I was sharing with someone yesterday, you may have a physician that comes to you and they say the pH is elevated, the PCO2 is elevated, and the bicarb is elevated. I don't understand. What are you going to do? Say, well, you got to give me some numbers?
No, you can't. You can't do that.
You can't do it. You've got to be able to understand it. Now, in actuality, when you take your boards, I'm being very practical, there will be numbers. But I'm preparing you also for clinical. And you will have a physician. And they're not coming to challenge you. They don't understand. And say, I've got all of these elevated. What kind of blood gas is this? You need to be able to explain it to them. Does that make sense? Okay. So if you got 1 through 4, you should have been able, and 1 through 5 actually, you should have been able to navigate through the rest. But nevertheless, okay. Any other questions on number, what, 10? Was that 10?
10.
10.
That's just it. 1 through 4, I knew. I mean, when I put that down, 1 through 4, I got them all right, and I knew that. There was no question. I mean, I didn't question myself. I got the rest of it and just crash and burn.
Well, you need to assess and see why. And I can't tell you why. You need to ask me or tell me why, and then I can help you. All I can tell you, in a partially compensated blood gas, the pH is not normal, and in a partially compensated metabolic alkalosis, the pH is not decreased, it's increased. That's why you need to have something like this. You do it. Or even if you don't want to do this, and some of you like to see numbers, write the normal values down. And then on the acid side, put acid. On the base side, put base. Do what you have to do. Okay. Number 11. In partially compensated respiratory alkalosis. Okay. So which one of these is respiratory alkalosis? It looks like over here. This one here.
Last one.
This is base. This is base. Yes? So that's partially compensated respiratory alkalosis. And partially compensated means the opposite has to be occurring as well. So we got metabolic acidosis. Right?
Right.
All right. So in partially compensated respiratory alkalosis, alkalosis, the bicarb is decreased, which makes the acidosis. The PaCO2 is decreased because that's the primary problem. And the pH is what?
Increased.
Any questions? And my thing is, don't you dare say in a partially compensated blood gas, the pH is normal. It is not. That's what I found for some of you that struggled. You altered the pH. It's not compensated. Go back to number 5. The purpose of compensation is a normal pH. So if it's partially compensated, pH is still out of range, but these are opposite. See this? This is acid, this is base. This is base, this is acid. See it? Hi. How are you? Look at you! Oh my goodness!
I was just in the area, stopped there.
How are you doing?
Good.
Good.
Thanks.
What year did you graduate?
Oh, was it 2 years ago?
I don't know.
Yeah, it was 2 years ago.
Was it two? So you're the class of 11?
Yeah, I think so. I think that might be it. I don't even know.
Everybody, this is Damien, the class of 2011? I don't know, remember.
I don't remember either.
How you doing?
Good.
Good, good. You gonna sit in or?
Yeah, I'll sit in.
Come on,
I'll
have a
take a
seat.
too.
Good to see you. Oh my goodness, look at that hair on your face. Oh my God, there's no hair on your head. Boy, have you changed. Good to see you, Damien. Okay, any questions on number 11? Somebody's being tweeted. Oh, or somebody's, okay, good, all right. Number 12. Now, number 12, it says chronic. What's another word for chronic?
Compensated.
All right, chronic ventilatory failure. What's another term for ventilatory failure? Respiratory acidosis. So in chronic ventilatory failure, the bicarbonate base, right?
Yes.
The PCO2 is acid, and now the pH is normal. And for some of you, you put normal/acid, and that was fine. Now the pH is normal, okay? So our primary problem is an elevated PCO2, which is acid. The compensatory mechanism is metabolic alkalosis, which makes the base increase. You got two conditions, but it says chronic, so we know the pH is within normal range, right? Yes. Most of you did good on that. You kind of weren't certain with 10 and 11. Any questions with number 12? Let's turn it over. Number 13. In compensated, okay, compensated means what? pH is normal. So the first thing you probably should have filled in was that pH is normal, and some of you put normal/acid is normal, but on the acid side of normal, which is correct. Okay, so in compensated metabolic acidosis, the bicarb is what? Decreased. Because that's the primary problem.
Right.
Right. The PCO2 is what? Decreased. Because we want respiratory alkalosis. And then the pH is 1. Okay? Any questions? Some of you are confusing yourselves, and I don't know why. I don't know if it's anxiety. You got to get over that. Some of you, before you came here, and I'm not a psychologist, you doubted yourself. I can't sell you confidence. I cannot. Some of you had right answers, and with your wonderful erasers, erased it and put the wrong answer. And I'm like, uh-oh, not good. Okay. Tissue hypoxia is represented by the SaO2, which is a reflection of oxyhemoglobin. 98% oxygen is carried by hemoglobin. Okay. Hypoxemia caused by intrapulmonary shunting, and I just threw that in there. Hypoxemia, period, is low oxygen in the blood, is represented by the PaO2. That's all I was looking for. Okay? All right. Some of you bombed out 16 through 20. For each of the following, give the correct acid-base interpretation, and I have up here using compensated or uncompensated. Some of you didn't use it, so it was marked wrong. Because it's wrong. You have to follow instructions. Okay. Acute means what? Is that a compensated or compensated?
Uncompensated.
So alveolar hyperventilation is respiratory alkalosis. So uncompensated respiratory alkalosis is the blood gas interpretation for number 16. Any questions?
Wait, can you repeat what you just said?
Uncompensated respiratory alkalosis. Okay? All right. Chronic hypercapnia. Chronic means what? Compensated. Hypercapnia means what? Respiratory acidosis. And then it has with hypoxemia. So the correct answer is compensated respiratory acidosis with hypoxemia. Some of you, which I knew you understand, even told me chronic ventilatory failure with hypoxemia, and you are absolutely correct. This is all I wanted. This is all I was asking for. Number 18, decreased minute ventilation. That's uncompensated respiratory acidosis. Here's the decreased minute ventilation, and over here I have respiratory acidosis. Any questions? Okay, number 19, respiratory insufficiency. What's the difference between number 16 and 19? Here we go. Respiratory insufficiency is respiratory alkalosis, right? But it's also with hypoxemia. So the difference between 16 and 19, 16, the oxygenation status is normal, and 19, it isn't. So for number 19, it is uncompensated respiratory alkalosis with hypoxemia. I'm on number 19, respiratory insufficiency. Any questions with that? So the difference between 16 and 19 is the oxygenation status. In number 16, I don't see any oxygenation status, so I'm assuming it's normal. It hasn't been given. So we're interpreting in that as uncompensated respiratory alkalosis, right? But number 19 says respiratory insufficiency, the same case, but now I know that the PO2 is low. So it's uncompensated respiratory alkalosis with hypoxemia. If you didn't put the hypoxemia, it's wrong because it's not a complete interpretation. Any questions? All right. Now, number 20, acute respiratory failure. Acute means uncompensated. So you could have done this several ways. You could have said uncompensated respiratory acidosis with hypoxemia, or you could have said acute ventilatory failure with hypoxemia. Either one was correct. And some of you, if you wanted to put acute hypercapnia with hypoxemia, that would have been correct. Any questions? Okay. So if you need help, take this and study it. If you need help, bring these sheets or whatever you want. Again, if this doesn't work for you, find something that does. I'm not saying this is the only way, but I don't know how to make it any simpler, but you figure out what you need. Okay? Yes.
I'm interchanging the words hypoxia and hypoxemia. Is that okay?
Don't worry about that as long as you have it. Hypoxemia is PaO2.
Right.
Hypoxia is
SaO2.
SaO2. But as far as this, as far as these interpretations, either one I'll accept, because at least you're in the ballpark. Okay? So remember, the pH, the PCO2, and the bicarb give you the acid-base status, but now we've started adding, right, PO2 and SATs. So if they're decreased or one is decreased, you can't ignore it. So there is a big difference between 16 and 19. There's a difference between 18 and 20. And if you didn't have the hypoxemia, it's not a complete interpretation. Any questions? And what I generally hear after a quiz is you were nervous. Okay. When you take your boards, are you going to be nervous? When you finish the program, you have to pass your boards. And for the registry, you're going to have 2 hours, 120 minutes to answer 100 questions. That's all they give you. And I didn't establish the rules. I would love to give you 4 hours. But some of you would change correct answers to incorrect the more time you have. So you got to move. That's the way it is. And when you take your boards, not relative to blood gases, you will not use a calculator. You will not. The only thing that you can do is when you take your boards is take your ID, your driver's license or your state ID. They give you paper, they give you pencil, and you do not have a calculator. Okay? And I'm not threatening you, I'm just trying to tell you this is reality. Okay? All right. And the majority of you are petrified of math. Math is just numbers. Most students are petrified by mechanical ventilation. It's just a machine. It only does what you tell it to do. And everybody's saying, yeah, that's easy to say, Kathy Miller. Yeah, right. But you have to develop the mindset that you're going to do this. So again, if you need help, because I have to move on. I'm not done with blood gases. And I'm a little hesitant to go on. We haven't gone through the causes of metabolic problems. I got to get there. I got to talk to you about potassium, and I've got to talk to you about hyperglycemia, and I've got to talk to you about lactic acidosis. And I can't because I'm continuously giving you respiratory failure, respiratory insufficiency, or respiratory problems, and you're tinker-tottering. If you need help, get it. And again, I'm not offended if you don't come to me, but you better go to somebody. All right. Okay. Pull out those words. Did everybody write this down? And again, if this doesn't work for you, figure out what does. Okay? Any questions? Let's go through this one. The pH is what? This one here. Acid.
Acid.
The PC. Now, right there, I can look at that right there, and I know that's a partially compensated blood gas, even if I don't have this, because the pH is not matching respiratory alkalosis, and I know that pH must match 1, right? So automatically, even if I don't have a bicarb there, I know this is a partially compensated blood gas. Can you all see what this covered? I know this is partially compensated metabolic acidosis, even without a bicarb, because that pH is not matching respiratory alkalosis. But I see that that respiratory alkalosis is a compensatory mechanism for metabolic acidosis. Everybody see that?
Mm-hmm.
See, when you become proficient in blood gas interpretation, you can interpret a blood gas just with partial values. Everybody see that?
Mm-hmm.
I can make that call. It's partially compensated. And then this is acid. So I know this, the pH is matching that, so it's partially compensated metabolic acidosis. Yes, sir.
See, I wouldn't be able to make that call just because when I'm thinking partially compensated, I'm thinking that if I assign that pH a number, just theoretically, if that pH was at say 733, I would say, okay, it's starting to normalize, so it's partially
The
compensated.
pH is not normal. A normal pH is
7.35.
7.35 to 7.45.
I understand that. What I'm saying is if I'm looking at the pH and that number said 733, I
It's
would...
what?
It's starting to normalize.
No, it is not starting
Okay.
to normalize. It is acid.
Okay.
It is not.
I understand that. I'm saying if it's on its way to 735 to be partially compensated. I understand what you're saying.
It could be 7.33, and the next time you take a blood gas is 7.29.
Right.
You cannot do that. If you call it what it is. If it's not 7.35 to 7.45, it is not normal.
Gotcha.
You can't make it what you want it to be. It is what it is.
You're right. You're right. I cannot do that.
You cannot do that. All right. Okay, this one. Again, the pH is acid. right?
Yes.
Yeah.
Now, I'm gonna cross this out. We don't see that. And this is base. I know this is a partially compensated blood gas. That pH does not match the bicarb. And I know that pH must match something, right? So I know it's got to match respiratory, even though I don't have a number there. So I know that's partially compensated respiratory acidosis. And what's beginning to compensate for? Metabolic alkalosis. Everybody see that? All right. And then so now I know my PaCO2 is elevated, and that's acid. Okay, any questions? Any clarity? Okay, let's move on. Somebody asked yesterday about the 50-60 rule. I will briefly go through that. The 50-60 rule, first of all, we know is dealing with respiratory. That's PA, the 50, is PaCO2 50 or greater. We know that's respiratory acidosis, right? And the 60 is dealing with the PaO2. So when my PaO2 is less than or equal to 60, this can be uncompensated respiratory acidosis with hypoxemia. Everybody agree?
Yes.
It can be acute ventilatory failure with hypoxemia. Yes?
Yes.
Okay. You can call it acute hypercapnia with hypoxemia, but it's also classified as respiratory failure. And pulmonologists and intensivists will use this diagnosis, respiratory failure. If that is a diagnosis, then you know as a therapist what the blood gases will look like. The PCO2 will be greater than 50 or greater. Most of the time it'll be much greater. And the PO2 will be less than 60. And it's respiratory failure because if you look at it from the perspective of ventilation, the patient's not adequately ventilating anymore, are they?
No.
Or is he or she? No. And then if you look at it from the perspective of oxygenation, peripheral chemoreceptors have kicked in, right? So it's respiratory failure. The lungs are not adequately ventilating, and the lungs are not adequately oxygenating. So we call it failure. Any questions? Yes, ma'am.
This is about the peripheral chemoreceptors versus the central ones. My question is, Ms. Miller, if you go below, if your PaO2 goes below 60, so you're using your peripheral chemoreceptors to breathe, but you can come back from that, right? Like
If you're not a CO2 retainer,
okay, but a CO2 retainer is chronically
hypoxemic, and this,
I'm doing this.
they're always in respiratory failure.
they're always in respiratory failure, and that would be their chronic. That would be considered chronic respiratory failure.
Yeah, that would be normal for them.
Okay, but you can go, if you go below, say you have an accident or something, you're having issues with your lungs, your PaO2 goes down significantly below 60, your peripheral chemoreceptors start to work. If you get that PaO2 up again, you can turn back on your central chemoreceptors.
Well, you don't, yeah, but yeah, you're right. I know what you're saying, yes. Your peripheral chemoreceptors will shut down, and then your central chemoreceptors will be reactivated.
Reactivated.
Yes, yes, absolutely. That's what happens to people that have pneumonia, or people who were in an automobile accident, or whatever. Yeah, we can breathe off our hypoxic drive, but once that underlying cause is resolved, then we go back to our central chemoreceptors. CO2 retainers cannot. Yes, you're absolutely correct. Okay, any other yes?
I just, Kat mentioned this earlier about hypoxemia and hypoxia.
Mm-hmm.
The PaCO2 is hypoxemia.
No,
That comes first?
PaCO2 has to do with ventilation.
Okay.
Ventilation.
Yeah, I'm getting a little
If we
confused
want
on
to
that.
determine how well a patient is
Mhm.
ventilated, we assess the PCO2. That's breathing in and
Right.
out, tidal volumes, minute ventilation. That
Okay.
has nothing to do with oxygenation,
Okay.
okay?
That's what I messed up
Oxygen
on.
is carried two ways.
PaO2,
That's
SaO2.
2% when we look at a blood gas,
98%.
and then we read it as this in a blood gas, that's 98%. This is hypoxemia.
That's
Not enough
hypoxemia.
oxygen
Okay.
in the blood.
Yep.
This represents tissue hypoxia. It never changes.
Okay. I needed a clear clarification.
Okay, this is hypoxemia. Not enough oxygen in the blood. How do I know that? PO2 less than 80. This is tissue hypoxia. Yes.
If you have hypoxemia, that will more, if it's not caught or fixed, that will more than likely lead to tissue hypoxia, but not always, right?
No,
If
not
you
always.
fix it.
Sometime if we can get to the patient soon enough, we can resolve this and this will never happen.
Okay.
Okay? And this will generally happen first because that's only 2%. This is 98%. And yesterday, with Ms. Sharkana was going through the oxyhemoglobin dissociation curve, I don't know if you all remember, but at a PO2 of 60, your saturation is still 90%. Because the majority of oxygen is carried this way. Yes.
Once you reach the point of hypoxia, is that reversible or is that?
Depending on the etiology. In the CO2 retainer, no. Okay? But if it's us because we have pneumonia or excessive secretions or whatever, yeah, it's reversible.
Okay.
Yeah. If death doesn't ensue, yeah, it can be corrected. Yes.
So does the COPD patient that's a CO2 retainer, will they always have tissue? Is their SA always going to be, their SAT will always be low?
Their SAT won't be low, their PO2 will be low.
Okay.
Peripheral chemoreceptors is PO2 of 60 or less.
So they're having a problem with the ventilation, but their tissues is fine. It's still getting to their tissues.
Yeah, still getting to their tissues, but they'll be chronically hypoxemic. It'll be this issue. And then the body tries to, and I'm not going to get into that now. We'll talk about next semester. The body will try to do things to compensate, which really creates other problems, but nevertheless. Okay. Somebody, it was only one person, put patient assessment. Don't worry about patient assessment other than what we tell you right now. That's pathophysiology. You're not ready for it. You can't do patient assessment if you can't interpret blood gas. Because if you can't interpret the blood gas, you can't make a call what to do for the patient. Everybody understand that?
Mhm.
So let's not get ahead of the game. The ship has sailed, but you can't go further than the ship. So we're moving 10 miles an hour. You can't fly 25. Where you going? You need to be navigated. So back up and just hang with us. Okay, and I know I'm using street vernacular, but you understand. All right. Any other questions? Yes, ma'am.
Okay. I understand that the 50-60 rule there definitely is respiratory failure.
Yes.
Excuse me. If the person still ends up with somehow a PaCO2 of 50, but that PaO2 climbs up 75 to 80,
Then it's ventilatory failure.
it is no longer respiratory
It is
failure.
no longer respiratory failure.
Okay. Just
Because both have to apply.
Yes.
Then it's just respiratory acidosis.
I just wanted to make sure I had
Ventilatory
it right.
failure. Then it's just ventilatory failure.
Yes.
And when you say ventilatory failure, oxygenation status is normal.
Yes. Oh, just clear. Thank you so
Now, that won't happen in the CO2 retainer, but it could happen to somebody else. Right. Make sense?
Yes.
Yes, you got it. You got it. Any other questions? All right, everybody good? Okay. Okay, pull out the worksheets that I gave you on Monday with the math. And while you're doing that, does anybody have any questions on the magic box? What do we use the magic box for? To find air to oxygen ratio. And the oxygen part is always going to be what number?
1.
Wood. So actually what we're doing is solving for the air, right? All right. And what's the purpose of finding the parts of air to the parts of oxygen? What's the whole purpose behind that? What were we talking about when we went into those math problems? As far as oxygen therapy. What kind of oxygen devices are we referring to when we determine air to oxygen?
High flow.
High flow. That's the whole purpose. High flow. Okay? So nobody has any questions with the magic box.
Can you go over again what the magic box?
The magic box determines the air to oxygen ratio. You have an FiO2 given. And you want to know what are the parts air and what are the parts oxygen, right? Okay. And what's the rule of thumb that Ms. Pope gave you? 21, you use 21 for an FiO2 of what? 40 or less. And you use what factor if the FiO2 is greater than 40?
20.
Okay. Got that? All right. How do we calculate, or does anybody have any questions on the formula for finding an FiO2? You got the air parts, you got the oxygen parts, but now you're trying to guesstimate. I call it guesstimate.
Airflow times 21 plus
Yep.
the O2 times
We'll give you
100 over total flow.
Right. Any questions with that?
And the total flow on the bottom when you add the reagents together, right?
Yes.
Okay.
You add the parts together. So if you got 3 parts air and 1 part oxygen, that would be 4
Okay, on the bottom.
on the bottom. And then if it says the apparatus is running at 8 liters per minute, 12 liters per minute, or whatever it's running at, after you do that math, you multiply it by that liter flow, and that gives you total flow, right?
Yes.
And we assume that it's a high gas flow system. Well, it is. But in reference to patients, how will we know? How can we determine if it is a high gas flow system? We got the air to oxygen ratio. We got the total flow. Now we want to make sure that total flow meets or exceeds the patient's inspiratory demand. How do we find the patient's inspiratory demand? Minute ventilation times 3. Any questions with that?
3.
And I'm never going to give you a minute ventilation. You know that. I'm going to give you a tidal volume. And you have to take it from there. Okay? What's the formula for minute ventilation? Times respiratory rate.
Respiratory rate.
That gives you your minute ventilation. Okay? Now let's say we're not going to do any math. We're not, but I'm just going to make a point here. Let's say the total flow through a device equals, I'll just pick a number, 30 liters per minute. And we have it on, we calculated it 3 times, and we know the total flow is 30 liters per minute, right?
Mm-hmm.
But we take the patient's minute ventilation, and multiply it by 3, and we got the patient's inspiratory demand. Yeah?
Mm-hmm.
And let's say we calculate that number, and their inspiratory demand is 38 liters per minute. That's not a high gas flow system.
Right.
Good morning, sir. And I'm sorry we don't have any candy.
Guess what day?
What day is it?
Guess what day it is?
November something. Is it your birthday?
No,
Oh, well, it's not mine.
it's hump day.
Oh! Okay, we're humping
Okay.
with inspiratory flows and getting
Okay, I can
ventilation.
tell, I had no idea what you were talking
Right,
about.
we're humping. We're getting there. Hump day! Mike, Mike, Mike! I love that commercial. Okay. So, we've talked about high gas flow systems, right? And the purpose of a high gas flow system is meet and exceed the patient's inspiratory demand. But if you find that your total flow coming from an apparatus does not meet or exceed your patient's inspiratory demand, then it's not a high gas flow system for this particular patient. So we've calculated our total flow. I'm just picking numbers to make a point. It's 30 liters per minute. We did it 3 times. I did it, Kyle did it, Rachel did it. We are on the money. But we did the patient's minute ventilation, multiplied it by 3, and that patient, this particular patient's inspiratory demand is 38 liters per minute. At this point, even though by definition of a high gas flow system, it is delivering a total flow, but it's not a high gas flow system for this patient. So we're going to have to do something. More than likely, what do you think the first thing we would do? Turn up the flow and make sure that our flow at least reaches 38 liters per minute. And that's a good certification question. They'll give you a tidal volume. You'll be given a minute ventilation. And you know you have to calculate flow. Then you have to do the total flow for the apparatus. And you find that they're not equal. And you find the patient's flow is less. That is not a high gas flow system for this particular patient. So I'm doing this, I'm telling you this, because in most cases, I want to say probably, I'll use whole numbers, 9 times out of 10, high gas flow systems indeed are high gas flow systems. But there's always that one patient where, or circumstance, where the total flow will not meet the patient's inspiratory demand. If it does not meet it, then it's not a high gas flow system, and you're going to have to do something else. And more than likely, the first thing you do is just increase the flow, up the flow, if it's possible. Okay? Any questions? Okay, let's go back to low gas flow systems. We talked about, and I know Ms. Pope has talked about variables. When we say the FiO2 is variable based upon the patient's minute ventilation, what are the 2 things that make up a patient's minute ventilation? Respiratory rate and tidal volume. So if their tidal volume, and I'm just using for lack of better term, shaky, it's not consistent, or if their respiratory rate goes up and down, or if patients are using their accessory muscles, right? All those are variables, and it can alter the FiO2 of a low gas flow system. So if you have a patient that comes in like that, your choice initially may you want to give them a high gas flow system just to get them stabilized, and then once they're stabilized, maybe you want to take them off and just give them a nasal cannula. Does that make sense? Mm-hmm. So when we say the FiO2 is variable, it's variable upon the tidal volume. What's going on each breath? Is it uniform? Is the respiratory rate variable? Is the patient using their accessory muscles? Are they in distress? All those are variables. And I'm not saying that a low gas flow system won't be effective. I'm not saying that. But that just depends. That will be a determining factor. The doctor may write an order, a valid order. The doctor may write a valid order for a nasal cannula at 4 liters per minute. But you go in the patient's room and you see their orthopnic, you see their dyspneic, You see sometime they're taking in a deep breath. You see them diaphoretic. You may not want to put them on a nasal cannula at 4 liters per minute. You might decide at that point you want to use a Venturi mask just to get them out of distress. And then once they get stabilized, then put them on a nasal cannula at 4 liters per minute, right? This is what we do. And it's going to take time for you to get there, but I'm just making points so for you to understand. It's not all about being task-oriented. It's you knowing, for lack of better terms, your stuff and making decisions. Yes?
Would that be a situation where you could make that call without changing the doctor's order? Because I know that a lot of times we can do that.
If it's protocol in your department, we have protocols, absolutely. Anybody comes in ER short of breath, we don't know right at that point, or even the doctors and nurses at that point don't know the etiology, meaning we don't know if it's cardiac or respiratory. If they're short of breath, if they're having a difficult time breathing, immediately we put them on oxygen. Then figure out what's going on. Okay. Now we know, and this is a term student use. I don't like it, but you'll understand it. If we know it's a frequent flyer who is our CO2 retainers, we may not use that nasal cannula at 4 liters per minute, and you understand why.
Yes.
You'll put them on 1 or 2 liters per minute, or just put them on a 24% Venturi mask from the get-go. Nevertheless, you don't need a blood gas, and you don't need a pulse ox to put a patient on oxygen. Do that later. Oxygenate the patient. Make sense?
Yes.
All right. Okay, we got tidal volume times respiratory rate. We've got high gas flow systems. You know how to calculate the FiO2, and you know how to calculate the air to oxygen ratio, right? And you know how now the total flow. Okay, let's look at this sheet. Has anybody done number 1?
Yeah.
I did some of it. I didn't do all of it.
Well, no, you're not.
I got,
I
I
have more questions.
Yeah, I have more questions on that one, but I did a lot of it this sheet.
We're going to go through it. Okay, it says calculate the patient's tidal volume. I've got maximum in pounds. And so with 1A, whatever that tidal volume is, you're going to use that in the entire problem, right?
Right.
Right.
Okay, I'm going to walk you through it. And this is a setup for mechanical ventilation.
Okay.
When it comes to mechanical ventilation, you're going to have to calculate tidal volumes, minute ventilation, inspiratory time, i.e. ratio. So when you get to the spring term, you'll know how to do this. It's awful, God forbid awful, to try to learn mechanical ventilations, try to learn blood gases, and the math with that. So we're preparing you, and everything that you're learning now, we hold you accountable. I hold you accountable for next semester. So next semester, we may be on, or whomever is teaching, hyperinflation techniques. And if they ask you to calculate the duration of an E-tank, you need to know how to do it. And all I can do is guarantee you, if you hang in, when you take your boards, you'll pass it. That's all I can tell you. If you don't believe me, you won't. Okay. Calculate the patient's tidal volume, and I've got maximum pounds.
Maximum pounds.
So the patient weighs 44 kilograms. How are we going to change kilograms to pounds?
Multiplied by
Multiply
2.2.
Woo! And I have no idea what this is, so but somebody tell me what it is.
96.8.
96.8. Okay. So we can leave it at 96.8, or we can just say, what, 97, right? All right. Now what are we going to do? Times what?
By 4.
Where we get that 4 from?
3 to 4.
3 to 4 in pounds, and then I ask for maximum, right? Any questions?
Nope.
Okay. So 97 times 4, do the math.
388.
7.2.
Okay, 388.
Yeah.
388.
Using the
Is
whole
this
number.
liters per minute?
Milliliters.
Milliliters. So the patient's tidal volume is 388 milliliters, right?
I know.
Yes. And if we had to, we could say 0.388 liters, but we're not going there for now.
Okay.
All right. Any questions?
Nope.
So the patient's tidal volume is 388 milliliters. Next it says calculate the patient's anatomical dead space.
So
How do we do that?
It's basically liters per milliliter.
Okay, so what was the patient's weight in pounds?
96.8.
96.8, so let's use the
97.
97.
97. So the patient's anatomical dead space, that's A and A, is what? 97 what?
Milliliters.
Milliliters. Very good. Any questions?
No.
No, not
Okay.
yet.
Calculate the patient's alveolar ventilation. How do we do that? It's two parts to a tidal volume. That part that's not involved in gas exchange and the other part that is. How do we get it?
Subtract the 2.
And so
V-
what's the answer?
VT minus V beta. 291.
291 milliliters?
Mhm.
Looks good to me. Any questions? So the patient is moving 388 milliliters per breath. We know that anatomical dead space is equal to 1 cc or 1 milliliter per pound of body weight. This is the part that the patient does not exhale to keep the airways open on expiration, right?
Right.
All right. And this is the part of the tidal volume that's directly involved in gas exchange. Yes?
Yes.
All right. Now, it says calculate the patient's total time. You had a formula. I was going to give you the formula, but you all insisted to get it sooner, so you got it. Ms. Pope gave you a formula. Total time. 60 divided by the respiratory rate gives you total time. What's this patient's respiratory rate? 12. So 60 divided by 12 breaths per minute gives you what? 5 seconds. So how long does it take a patient to breathe in and out? This is saying total time. Every breath is taking them 5 seconds to inhale and exhale. Yes?
Is that also the same as, like, just adding the ratio, or is it?
Ratio? No, ratio is different. Total time, inspiratory time and expiratory time is time in seconds. Ratio is parts. It's a difference. Okay. Good question, but we'll get there. Any questions with this? Were you able to do this?
No.
No, I
Okay.
didn't.
60 divided by 12, 60 divided by the respiratory rate, and then you can have this. 60 divided by the total time, it would have to be given, will give you a respiratory rate. So let's look at this. Say total time is 6 seconds. This is not number one, I'm just making a point. Write down total time is 6 seconds. What is the respiratory rate? 10. That's how you find it. And so what is total time? Total time is how much time it took the patient to inhale and exhale that tidal volume. And in this case, 5 seconds. Make sense?
Yes.
Okay, so let me give you another one. Patient's total time is 3 seconds. Because I wanted to come out even for you guys now.
Okay. 20.
So the patient's respiratory rate is 20 breaths per minute. Got it? Everybody see what we just did? Okay. Question, Ebony? Okay. Everybody with me? See why you can't get ahead of the captain of the ship? Where you going? If you go back to look at those formulas that Ms. Pope gave you, it's there. Okay? Because I did them. But I did, one thing that I did check, Desjardins, he changed his values for the tidal volume, but that's okay. In his 5th edition, I believe you all are using the 6th edition, he has 5 to 7, but in his older editions, it was 7 to 9. So he changed it, so we'll use what the book has. I'm not going to squawk about that. All right, so we know that the patient's total time is what?
5 seconds.
5 seconds.
Okay, it says now calculate the patient's inspiratory time and expiratory time in seconds. Let's hold off on number E. 1F says calculate the patient's minute ventilation. How you gonna do that? Tidal volume times what?
Respiratory rate.
Okay, so the patient's tidal volume is what? 388, and the patient's respiratory rate is what?
12.
12.
Do the math. 4.7 liters per minute. Did everybody get somewhere in there? All right. That's 1F. Any questions? Okay, let's do 1G. It says calculate the patient's minute alveolar ventilation. So here is alveolar ventilation, right? Back over here, 291. I didn't make this up. You all gave me the numbers. So now we want to do minute. Look at this dot over here. It's a difference between this and this. This is one breath, one tidal volume. This is for a minute. How are we going to get that minute? Multiply it by the patient's respiratory rate. Patient's respiratory rate was 12, yes?
Yes.
Multiply 291 times 12, or 0.291 times 12. I don't know what the answer is. 3.5 liters per minute. Okay. Any questions with that? Now let's look at this. I'm making a point. This is the patient's minute ventilation, right? This is how much air they move in and out of their lungs in 1 minute. Do you agree? But look how much was involved in gas exchange. 3.5 liters. No, that's not shunting. This value should always be more than this. Why is this value less? Because it's only part of the tidal volume. Remember, the rest is anatomical dead space. Everybody see that? So my point is, this value, your minute alveolar ventilation, should never be more than your minute ventilation. It can't be, because it's 2 parts of a tidal volume. Did I confuse anybody?
No.
This value, minute alveolar ventilation, will always be less than this. And why? Because the rest is anatomical dead space. Does that make sense? Okay, any questions on 1A, 1B, 1C, 1D, F, or G?
Go back to G again, I'm sorry.
Yes.
What did we use to get that?
Right here.
Oh, okay.
Alveolar ventilation
Multiply the respiratory.
times the respiratory rate, which was given in this scenario, 12.
Right.
And it gave us 3.5 liters per minute. Yes, Marie?
That was the same question, but I agree with it. I was just doing it wrong.
Times
Sorry.
12. Okay. Yep.
Any questions?
That's correct. Okay. So,
Nobody cares about this stuff except us. It's not a secret. But this is why we're in respiratory care. We specialize. And so that's why the healthcare community and physicians will come to us, because we know this. We're experts in this. Yes, ma'am.
So you said that this first problem is set up for mechanical ventilation?
Yeah.
So this is something that we're going to get
next year when we do it.
This is not going away.
But this is like the same scenario, we get over and over again.
I am asking second-year students with mechanical ventilation, weaning, hemodynamics. The patient's minute ventilation is what? Tell me, what is the tidal volume? They are calculating IE ratios on the mechanic. Oh, yeah, I forgot that. Don't forget it. Yeah. This doesn't go away. Fair game, IE ratio. Yes. Any other questions?
So,
Yes.
just minute alveolar ventilation is always less than the minute ventilation.
Has to be.
Has to
No,
be
we skipped
because
it so
Oh.
far.
Anatomical dead space. Has to be. So what is that saying to us? We now understand that all of our tidal volume is not involved in external respiration. Why? So our airways will not collapse when we exhale. Make sense? So let me look at it this way. This is PFTs, and I'm not expecting you to know the value. It doesn't matter. Remember yesterday, I had you suck in a real deep breath and blow it out, blow it out, blow it out, blow it out, keep blowing. Even after you exhale all the air out of your lungs, you forcefully can exhale, you still have air left in your lungs. Why? So your lungs won't collapse on expiration. And it's full of what kind of gas? Carbon dioxide.
Dioxide.
And then we can carry that even a little further. So now do you understand the function of a partial rebreathing mask?
Yes.
When a patient exhales, what's the first thing that goes into the mask? CO2 left from their anatomical dead space from the last breath. Make sense? Okay. All right. It's a lot to breathe in. Breathing easy though, yes.
When you calculate pounds versus when you like calculate in kilograms, like I noticed you come up with different answers.
It just depends on what's given, what's asked for.
So VA, I just want to make sure my VA is alveolar ventilation.
Kilogram.
Correct.
Okay.
Right.
But you still have to convert it to get the anatomical dead space if you have to go that way.
That's C?
Yeah. And the reason we're doing this because of
Right.
mechanical ventilation, you can use either
So,
or.
yeah, so, because VA multiplied by respiratory rate. Okay.
You make the call whether it's efficient or not. Get a blood gas. Look at the PCO2, see how well the patient's ventilating. Look at the PO2, see how well the patient's oxygenating. Look at the SAT. No, ma'am, we have other factors. You're in ER and the doctor says, put this patient on a ventilator. And you say, well, what settings? He said, I don't know. You're the therapist. You figure it out. You better know how to figure it out. And I've had physicians tell me, you figure it out. You know what to do. Yeah, I do. Where do I start? And then once I get the patient set up, and if I want to find out if I'm in the ballpark, do a blood gas. And your blood gas will let you know. I look at the PCO2 to see how well they're ventilating. I look at the pH to determine acid-base balance. I look at the PO2 and the hemoglobin, the saturation, to see how well they're oxygenated. And that will tell me where I need to go next or what needs to be done. Make sense? It's all going to tie in. And you can't make that call if you don't know how to interpret blood gas, because then you can't make the decision what to do for the patient next. Because you still don't understand the activity of the hydrogen ion. I'm making a point here. I'm not being condescending. Everybody with me?
Mm-hmm.
Yes.
All right. Okay. Now, the last thing we need to do on 1E, it says calculate the patient's inspiratory time and expiratory time. How are we going to find that? Well, up in the scenario, we have an IE ratio of 1 to 4. What does I stand for?
Inspiratory.
Inspiration. And what does E stand for?
Expiration.
Okay. So for this patient's breathing, an IE ratio of 1 to 4. Physiologically, 1 to 2 is good. It's okay. 1 to 3, 1 to 4, okay. But now, why is inspiration? You look at a tidal volume. One part of the tidal volume, and IE ratio is not time, it's parts. Inspiratory time is in seconds, expiratory time is in seconds. But when we talk about IE ratio, that's parts. So what this is saying, one part of their tidal volume is inspiration, and 4 parts is expiration. Okay? That's what this is saying. How are we going to get this inspiratory time and expiratory time? I see in this scenario the IE ratio is 1 to 4, yes?
Yes.
Add those together, and what's the total parts?
5.
5. Very good. All right. Now, we calculated total time, right?
Mhm.
And that equal what?
5
5
5 seconds.
In this particular case, it was 5 seconds. What we're gonna do now, we're gonna calculate inspiratory time. Write it down, TI. This is what we're gonna find. In this particular problem, IE ratio is 1 to 4, meaning 5 parts, right?
Mhm.
We're gonna take the total time, which is what? 5 seconds.
5
And
seconds.
everybody see where we got that from, right?
Right. Mhm.
Yes.
Then now we're going to take this IE ratio 1 to 4, which we said is 5 parts. This is 5 parts. All right? We're going to take total time 5 seconds and divide it by 5 parts. Everybody understand where the 5 parts come from?
Mhm.
Everybody understand where the total time of 5 seconds come from, right?
Mhm.
And when we do this, this gives us inspiratory time. So in this case, 5 divided by 5 equals what?
1.
So inspiratory time equals 1 second.
So you do total time divided by parts or parts divided by total time?
This is parts divided by, this is time divided by parts. If the IE ratio were 1 to 3, what would the parts be? 4. But in this problem, the IE ratio is 1 to 4. I did it this way to make it simple for you. Yes, sir.
So like in the book, when they're saying instead of using parts, they said the cycle was 5. Parts is the same thing as the combined cycles, right?
No, cycle is time.
Oh, okay,
Cycle is time.
okay. Because they kept putting in a weird plate, I wasn't sure.
So time
it's always
divided
5
by
would be parts, always 4 to 1, what is called parts. So
Yeah, if the IE ratio is 1 to 2,
Divided
how
by
many
parts.
parts? 3.
So time
If the
divided
IE
by
ratio is
parts.
1 to 8, how many parts?
Okay.
9. You take the parts of the IE ratio given and take the total time and divide the parts into it. All right, so that's why I got 5 parts from an IE ratio of 1 to 4, and the total time is seconds. Where did I get that from? 60 divided by 12 gave me 5 seconds. Okay, so when you do this, total time divided by parts, it's going to give you inspiratory time. So in this scenario, inspiratory time is 1 second. That's a horrible S, but that's an S. Does that make sense?
Yes.
All right. So how am I going to find expiratory time? Well, I have total time, which is 5 seconds. And I can subtract inspiratory time. We just found it right there, which was what? 1 second. And so expiratory time equal what? 4 seconds.
Okay.
Total time minus inspiratory time gives you expiratory time. So now we just did 1E.
Total time, expiratory time.
Everybody see how we did it?
Mhm.
Now I want to
Total
change
time.
things just to make a point here. Number 1, it says the IE ratio is 1 to 4. Just for the purpose of you understanding doing this, let's change the IE ratio to 1 to 3. You don't have to change it on your paper, just write it down. The IE ratio is 1 to 3. Everybody with me?
Mm-hmm.
We've gotten all the answers up to this point. So our IE ratio of 1 to 3, our total time is not changing. Everybody with me? We know where we got this from, yes?
Yes.
All right. Now the patient has an IE ratio of 1 to 3. How many parts is that?
4.
4.
So I'm going to put 4 parts here. From an IE ratio of 1 to 3. If you're lost, if you're not with me, let me know. IE ratio is 1 to 3. That's where we got 4 from. Yes?
Mm-hmm.
All right. My total time is still 5 seconds because 60 divided by the 12 respiratory rate is 5 seconds. But my IE ratio changed. And so when I do this, I'm looking for inspiratory time. So I know what this number is, but you all do it. 5 divided by 4 is what? 1.25 seconds. So my inspiratory time is 1.25 seconds. So if I go back up here, and I change this to 1.25 seconds, what's now my expiratory time?
3.75.
So my expiratory time now equals 3.75 seconds. So I can look at this. Okay, I got a tidal volume of 388 milliliters. And my patient is breathing at a rate of 12, yes? How much time does it take for them to inhale? How much time does it take for them to exhale? Well, based on an IE ratio of 1 to 3, of that 5 seconds, or total time for one breath, is 5 seconds. Of that 5 seconds, 1.25 seconds is for them to inhale, and 3.75 seconds is for them to exhale. And exhalation is always longer than inspiration. Why?
You're including
There's
that
parts to
dead
that
time.
expiration.
The pause.
Yeah, you're
There's a
including
pause.
the
No,
pause.
that equilibrium, but there's a pause when it goes.
What happens on expiration? Well, what happens on inspiration? What's the only thing going on inspiration?
Intake.
Inhaling air,
Air.
inhaling oxygen,
Right.
right? On expiration, gas exchange is occurring, external respiration. You're talking, you're crying, you're sneezing, you're coughing, you're swallowing food, you're swallowing liquid. All of that goes on expiration, so the body needs a longer time for expiration. The only thing going on inspiration is you inhaling room air or supplemental oxygen, right? Everything else we do is done on expiration, and it takes a longer time. Number 1, gas exchange, external respiration. You swallow food, you swallow liquid, you cough, you sneeze, you cry, whatever. All done on expiration. So expiration always has to be, or should be, longer than inspiration, other than a patient being on a ventilator, and that's a different world. Okay? All right. Okay, number 2, you should be able to do. Number 3, you should be able to do. Number 2 is total flow. Number 3 is the magic box, right?
Yep.
Okay. Number 4, the same thing. All right, a patient, let's look at number 5. A patient weighs 137 pounds and her respiratory rate equals 16. She's receiving an air entrainment device delivering an FiO2 at 31% with a set liter flow at 5 liters per minute. Calculate the patient's minimal tidal volume in kilograms. Do it.
$62.3.
It's a lot of information here, but it's all coming together. I haven't done the math, so I don't know what the answer, at least I haven't done it this year. So what's the verdict?
62.3.
62.3?
Mm-hmm.
So you can leave it at less, for all intent and purposes, let's just leave it at 62 kilograms. Now the next, everybody got 62 kilograms? Who doesn't? Who doesn't have it? What answer did you get? What'd you get?
685 by
Yeah,
multiplied.
yeah, that's right.
Well, you did the math wrong.
I know.
All right. Number B, letter B, 5B, calculate the patient's anatomical dead space. 137 is
37.
right there in the problem, right?
Mhm.
Okay, so what's the patient's tidal volume?
310.
310 milliliters? Does everyone concur? I haven't done the math.
Yes.
All right. And so the patient's anatomical dead space is what? 137? Yes?
Yes.
All right, so what's the patient's alveolar ventilation? Right here, 310 minus 137.
173.
What is it?
173.
173 milliliters. Okay? Yes.
Where did you get the 310?
They said they got the 310 with the tidal volume.
She got it.
Oh,
For the
yeah, sure.
minimum.
Minimum. I forgot about that.
It says minimum tidal volume in kilograms. 5 to 7 milliliters. You have to know that. So you have to take the 137 divided by 2.2. You with me?
Yeah.
Minimum tidal volume, you use the 5.
Right.
And then they got 310 milliliters.
Okay. Thank you.
Everybody there? Okay.
Yes.
The anatomical dead space, where we get the 137? Okay, I don't want to go any further. Did everybody get this tidal volume? Speak now, forever hold your peace, because we're moving on.
Yep, we got it.
Mendelssohn said, yeah, we got it.
We got it. We got it.
Okay. All right, calculate the patient's minute ventilation. How are we going to do that? Tidal volume of 310 multiplied by what? Which is 16. Let's do it. 310 times 16. 310 times 16. And if you want to, now you can change this to liters, 0.310, so you can get liters per minute. You can do it here, or you can do it afterwards. But this answer is in liters per minute, so however you want to do it. You can take it 0.310 times 16,
Yeah.
and that will definitely give you liters per minute right in your calculator. Or
Yeah,
if you
49,
don't, you're going to
60.
get 45, 48, or whatever the
Yeah,
answer
right
is,
about
and then you
that.
have to convert it. It doesn't matter. Doesn't matter.
5 liters.
So what's the answer? 4, 5, what?
4.96.
Okay, so you could have gotten
Five.
4960 milliliters, but you're going to change that to 0.496 liters. Right? Did everybody get that? Yes.
Really? Can we
I'll
just-
probably leave it as that.
Really? Okay.
Any questions?
If we did round it, is that,
You need to show me your work.
okay, that's fine, just so.
Okay.
Any questions on what we just did? Okay. Number 5D says calculate the patient's alveolar ventilation. Go back here and multiply by the respiratory rate. Do that. 173 times what? 16. The answer is?
2768.
I didn't hear you.
2768.
2768 or 2.76, or even if you want to change that to 2.7 liters per minute. Everybody got that?
Yeah.
And you see this number is less than that number. It's always supposed to be. Where did I get the respiratory rate? It was given. Any questions?
E, well, E's. That's respiratory flow. We're not there yet.
Any questions? Everybody still selling with me? This is not difficult. After a while, you're like, yeah. I don't even ask the second year students blood gases. I do not.
I don't know
Yes.
why I got
So, make sure,
the numbers wrong.
Why you turn your head to talk to me? Okay, now I can hear you.
It says to
labeled it
answer
wrong.
milliliters, so we would just keep it at the 2768.
No, number D is D is calculate the patient's alveolar ventilation, that's this.
But it has ML.
That's this.
Oh, okay.
Okay, I just did alveolar ventilation. I'm sorry, I looked at it wrong. We did a part in here we didn't have to, but nevertheless, it's good to do it.
Oh, okay, that's,
So D is actually this, and I don't have it in the problem, but if we did minute alveolar ventilation, it would be this. That's good practice.
that's funny.
Okay, any
We were all like,
questions?
how are we all alphabetically?
Right. I know, so.
Okay, 5E, calculate the patient's inspiratory flow rate or inspiratory demand. You figure that out. Do it. B dot I equals yes, you're right. Somebody give me a number.
How can we do that? Can we do that?
Can I help you?
By the respiratory rate.
Oh, sure. Go ahead. Okay. What is it?
14.88 or 14.9.
14.9 liters per minute. Did everybody get that answer? We took the tidal volume of 310 and multiplied it by what? What is minute ventilation? Tidal volume times what?
Respiratory.
Okay, so here's your answer right here, right? 4.96. All you got to do is multiply that by 3. Right there, it's right there. And the answer, somebody said, is 14.9. I want to know, did everybody get that? 14.9. So the inspiratory demand is 14.9. Right? Don't make it difficult. If you know it's minute ventilation times 3, you've done minute ventilation already. Yes? Just take your minute ventilation and multiply it by 3. See that? Okay. You just have to go back and pick it up again. So everybody concur, it's 14.9 liters per minute. I haven't done the math, I just want to make sure you all agree. All right, so that's number 5E. I'm going to skip F and G, let's do H. Calculate the patient's total time. How are we going to do that? 60 divided by what? 16. Okay. And why are we using 60? Because it's 60 seconds in a minute, right? Respiratory rate is in breaths per minute. Minutes cancels, and our total time is in seconds. I didn't do the first time, but that's the rationale for that. Right? So 60 divided by 16 equals what? 3.75. 3.75? So total time in this case equals 3.75 seconds.
Okay.
Any questions? Okay, so we just did 5H, total time. Yes? Yes. All right. Now it says calculate the patient's, I'm on 5I, calculate the patient's inspiratory time and expiratory time in seconds. What I'm going to do is, for right now, I'm just going to give you an IE ratio. I'm going to give you an IE ratio of 1 to 3. So you can write up in the scenario number 5, IE ratio is 1 to 3.
Okay.
I don't have to give it to you, but I don't want to confuse you. And I'll show you how to do this a little later. IE ratio 1 to 3. Okay? So we have an IE ratio of 1 to 3. That's how many parts?
4.
All right. So what are we going to do?
3.75 divided by 4.
Take the total time.
Total time, all right.
Can I erase all this?
Yeah. Total time divided
You all have this.
by parts.
I'm giving you an IE ratio of 1 to 3. Take the total time and divide it by the parts. So, what's the total time? 3.75.
divided by 4 equals
And the IE ratio is what?
0.94.
1 to 3, which is 4 parts. Okay. Take 3.75 and divide it by 4. It's going to be less than 1 second. I'm aware of that. 0.94.
Yeah.
So, inspiratory time equals 0.94 seconds.
Seconds.
All right. Did everybody get that? Yes?
Yeah.
Yep.
So, total time is 3.75 seconds. Yes? Yes?
Yes.
All right. What are we going to do with that 0.94? Subtract it. And so what's the answer? 2.81 seconds. 2.81 seconds. And however you want to add them up, you go back, add up to see if 0.94 and 2.81 equals that. So this is total time, this is inspiratory time, and this equals expiratory time. So in essence, inspiratory time plus expiratory time equal total time. So to make sure your math is right, take this and this, add them up, and does it equal 3.75? So you've done it correct. Any questions? If you had just waited till I got here, but you all insisted you wanted the formulas and you're still not doing nothing with them, that's what I get upset with you guys for. You want stuff, and then you get it. You don't know what to do with it. Wait till I get there. But I'm glad you asked. All right. Any questions? Okay. So now you can do 5F on your own and 5G on your own. You can do that, right? All right. Now it says calculate the patient's IE ratio. I gave you that. And then it says the sum of the total parts of the IE ratio. I gave you an IE ratio of 1 to 3, right?
Right.
So what's the sum of the parts?
4.
4. You got that answer. All right. All right. Now, what I want you to do before we leave here, let's calculate the air to oxygen ratio. Let's go back to 5F and calculate the air to oxygen ratio. So what are we going to do to set this up? Use the magic box. What's the FiO2 given?
31%.
31. So what's the rule Miss Pope gave you?
21.
Okay, what goes in the lower left-hand corner?
100.
What goes in the upper left-hand corner?
21.
21.
21. What's the FiO2?
31%.
Let's work this. Okay. 100 minus 31 gives me what?
69.
69. That's a numerator. This is up there. It's at top, right?
Yep.
All right. Now 31 minus 21 is what?
10.
10. This is the denominator. So I'm going to take 69 and divide it by 10. And what is that?
6.9.
6.9.
6.9. Woo! And we know oxygen is 1 part, right?
Right.
All right. So what's total parts?
7.9.
7.9. And then if we look at the top, it says the liter flow is set at 5 liters per minute, right? So we're going to take 7.9, where we know we got this from, and multiply it by 5 liters per minute. And so what's the answer?
39.5.
39.5 liters per minute. Everybody get that? All right. Now, it says, based on the patient's inspiratory demand, determine whether this device is a high gas flow system or low gas flow system. So in order to do that, we have to go back to 5E. What was the patient's inspiratory demand?
14.9.
What was it?
14.9.
Okay, so is this a high gas flow system?
Yes.
Yes.
Any questions? Yes, sir.
Would it have been acceptable to take that 6.9 and add the 1 and then round it to 8 times that by my liter flow? So that would have given me even 40 liters per minute?
Doesn't matter, it's still a high gas flow system. Doesn't matter. As long as you show me your work, that's okay. So for this patient, it is a high gas flow system, right?
Right.
So you see how we've taken all this information, put it together, and in addition to determining whether it's a high gas flow system or not, we determine total time, total time, inspiratory time. We've done all that, right? All right. I got one more to show you. Well, if you look at 6, 7, 8, 9, 10, 11, 12, this is practice math. I'm not going through it. You should know it. Practice it. And if you want to see me tomorrow, we can walk through it. I don't know the answers. I just make up stuff. But we can check and confer to see if it's right. I will have a calculator, and I'll sit and do the math with you. Okay, 6, 7, 8, 9, 10, 11, 12. One more thing I want to show you. And then I'm done. And practice. Practice. Make up practice problems. I hear, which is good, you guys get together and study. Make up stuff and give to the rest of the group. And if you don't want to do that, make it up yourself and practice this, practice this, practice this. If you have questions, you need to ask me. I don't want to hear the day of a quiz or a day of exam, I don't understand. That's your responsibility. Understand? Mm-hmm. You all are adults and I'm holding you to it. And I am letting you use a calculator. Remember, on your board, you can. Okay. Let's say you have an inspiratory time and an expiratory time. I'm going to make something up. Inspiratory time equals 1.5 seconds. That sounds good. Expiratory time equals 2.5 seconds. Yes? Mm-hmm. That's given. I gave it to you. What's total time?
4 seconds.
4 seconds. Tell me what the respiratory rate is. Respiratory rate is 15. Everybody got that? All right. I took 60 divided by 4, and that gave me a respiratory rate of 15 breaths per minute. See what we just did? All right. Now, I don't know what the IE ratio is. I want to know now, what is this patient's IE ratio? I'm going to show you how to calculate IE ratio. This is the formula. Write it down. It's on the sheet that you got, but nevertheless, TI divided by TI. That's 1 part inspiration. Any number divided by itself is what?
1.
Okay, so 1.5 divided by 1.5 is what?
1.
1 part. That's the first part of the IE ratio. This is parts. Now, TE divided by inspiratory time gives you the E part. So, 2.5 divided by 1.5. 2.5, where did I get that from? That's expiratory time. Divided by 1.5 gives me what? 1.6. 1.6?
Mm-hmm.
Okay, so this IE ratio in this case is 1 to 1.6. This is how you find IE ratio. Let me give you another one. Inspiratory time is 1.25 seconds. Expiratory time is 3.75 seconds. What's total time?
Right?
1.25 inspiratory time, expiratory time 3.75. So total time is what? 5 seconds. What's the respiratory rate? 12 breaths per minute. Everybody got that?
Mm-hmm.
All right. Now, what's the IE ratio? One to three. Did everybody get that?
Mm-hmm.
And what's the total parts of the IE ratio? 4. You got it. All right. I'm finishing up Module 2 on Monday. You will take Module 2 exam on next Wednesday. I have to move on. I will be here tomorrow after class. Any questions on any of these problems?
Module 2.
Bring your questions ready. The formulas that Ms. Pope gave you and I distributed are all the formulas that we are using. A few I didn't show you, so don't get upset. If I didn't show you, I'm not holding it to you right now. Okay? I don't want to tell you, I brought my workbook, but I don't want to tell you what else I want you to do until I go over it. And I love your emails, but I don't want you asking me emails, what does this mean? You'll know what it means when I cover it. So we will finish Module 2 on Monday, and you will take that exam on Wednesday. Okay? So I'll give you the rest of the workbook. Don't forget, fair game to go back and ask you how to calculate the duration of a tank. Fair game. Fair game to ask you how to calculate an IE ratio. Fair game, what's the difference between a low gas flow system and a high gas flow system? Fair game, those 4 types of hypoxias. Okay, we're moving on.
Any pointers?
Know those trade names and generic names know the function of epinephrine and racemic epinephrine. Know the trade names for albuterol. Know the classifications of anticholinergic drugs, Spiriba and Atrovent. Know if I give you a patient's pulse, when you need to stop the treatment. Know those drug classifications. Know the function of the parasympathetic nervous system. Know the function of the parasympathetic nervous system, right? Know those synonymous terms. Okay, so the only thing we've added are the trade names and generic names of the drugs. Know the difference between a LABA and know the difference between a SABA. Yes.
Do we need to know the dosages? Like
No. No.
SBN or MBI or anything?
No. No, I'm not asking dosages. I want to make sure you understand the fundamentals first.
Okay.
The purpose for me having you do the drug cards, the first day of clinical, when you walk in clinical with your bright, crisp blue uniforms on, what is your pocket going to be full of?
Drug
Your
cards.
drug cards. That'll be your little Bible. So if it's inaccurate, you look bad. That's the purpose of that. Because I realize all of this is not going to come. But no, I'm not. For the final, I will ask you dosages for albuterol. I am going to ask that. Ms. Hope insisted, and I'm going to do that. I'm going to let her see the final. I'm done with it, but as we go, I'm tweaking it. Okay? All right. See ya.
Thank you.